أحب الوفي الأمين الأغر فأهل الوفاء كلون السحاب.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على رسوله الكريم سيدنا محمد وآله وأصحابه أجمعين برحمتك يا أرحم الراحمين. All praise due to Allah, the Lord, cherisher, nourisher, sustainer and master of the universe, the most gracious, the most beneficent, the most merciful. Ya Allah, it is only you that we worship and your guidance that we seek. Ya Allah, keep us in a straight path. Ya Allah, show us the choice of blessings. Ya Allah, show us their mercy. Ya Allah, guide us. Greetings, salam, salutations on our beloved Nabi Muhammadur Rasulullah Sallallahu Alaihi Wasallam. It's time for Medical Files, brought to you by the Islamic Medical Association of South Africa, hosted by myself, Faizal MJ Suleman. Assalamu alaikum wa rahmatullahi wa barakatuh. And we welcome our listeners on Radio Al Ansar, CII Radio, Voice of the Cape, Radio 786 Sirius FM, Radio Islam and IFM Port Elizabeth, and all listening to us on audio streaming, Facebook Live, and other platforms. Our topic for discussion is inflammatory bowel disease, ulcerative colitis and Crohn's disease. And our special guest this evening is Dr. YUSUF MOOLLA, a gastroenterologist practicing in Umhlanga, Durban. Assalamu alaikum wa rahmatullahi wa barakatuh. Brother YUSUF, thank you for joining me.
Wa alaikum salam wa rahmatullahi wa barakatuh. Jazakallah for having me this evening on Medical Files. Always a pleasure to be part of it.
It's a pleasure hosting you, Yusuf. Now, just to introduce Dr. YUSUF MOOLLA. Dr. YUSUF MOOLLA obtained his medical degree from the University of Pretoria in 2007. He then completed his internship at King Edward Hospital in 2009. And before completing his community service in emergency medicine and pediatrics at Stanger Hospital in 2010, and after earning his master's degree in medicine and fellowship in internal medicine in 2015, he went on to specialize in HIV management, geriatric medicine, and then gastroenterology at the College of Medicine, South Africa between 2016 and 2019. During this time, Dr. MOOLLA served as junior consultant in the Department of Internal Medicine at Addington Hospital and later became senior registrar in gastroenterology at Nkosi Albert Luthuli Hospital. He has published articles in the South African Medical Journal, South African Journal of Oncology, Southern Africa Family Practice, South African Gastroenterology Review, HIV Nursing Matters, and recently in an international journal, Liver Communications. He has presented research and talks at local and national conferences, and as a specialist physician and gastroenterologist, Dr. MOOLLA specializes in the treatment of all common general diseases. However, he has an interest in the disorders of the digestive system, pancreas, and liver. He has a keen interest in inflammatory bowel disease, irritable bowel syndrome, and liver disease. In addition, Dr. MOOLLA is able to perform diagnostic and therapeutic endoscopy and endoscopic ultrasonic procedures. Dr. MOOLLA currently practices at the Gateway Center for Respiratory and Gastrointestinal Disease at Gateway Hospital and Life Mount Edgecombe Hospital, and is a member of the South African Gastroenterology Society and the College of Physicians South Africa. Dr. MOOLLA, I know half the program is gone. But I had to do justice to introducing you. Now, I introduced you as a gastroenterologist. What is a gastroenterologist?
So it's a field that involves focusing on the digestive system. So one has to become a physician firstly after becoming a graduate in medicine, basically a doctor, as we know it, a general practitioner. One specializes as a physician, and then one focuses on the gastroenterology system. So that involves our esophagus, our stomach, our small intestines, our large intestines, our liver, our pancreas. From the medical aspects, we treat a lot of medical conditions, and we also support that with practical investigations, which often involves endoscopy, the stomach scope, which we call a gastroscopy, and the colonoscopy. And we also do scopes which involve removing stones of the liver and looking at the pancreas as well. So that's the field that one zooms into as a gastroenterologist.
Mm-hmm. So, I did introduce our topic for discussion as inflammatory bowel disease. So, what is inflammatory bowel disease?
So inflammatory bowel disease is an autoimmune condition, and this condition, the spectrum of condition involves inflammation of the colon. So we often speak of this condition having a genetic predisposition. So patients may be predisposed to developing this condition, and for some unknown reason or some insult that occurs during their lifetime, this disease then is sort of stimulated, and the immune cascade is then active, which involves parts of the intestine becoming inflamed. And then we subdivide it into Crohn's disease and ulcerative colitis. There are other types of diseases, but those are the main subgroups of inflammatory bowel disease.
And are there different types? I mean, you did mention there are many subgroups. I take it that the subgroups form the different types of inflammatory bowel disease.
So we often speak of ulcerative colitis. So this condition involves inflammation of the large intestine. Depending on the distribution of disease, the distal part of the large colon could be inflamed, or the entire colon could be inflamed. That's ulcerative colitis. It involves the first layer of the colon, we call it the mucosa, that's inflamed. Crohn's disease, which is a cystic condition, which involves a different form of inflammation. The cascade system is slightly different. It involves all layers of the colon. It likes to involve the small intestines, especially the last part of the small intestines, and different segments of our bowel. So they are similar, but they do have different complications that can occur, and somewhat different presentations initially as well.
Speaking of presentation, what are some of the symptoms of this disease?
So this disease can present in a very mild way, firstly. So patients can be ill for some time before presenting to the general practitioner or complaining of symptoms or presenting to the specialist. Or it could be severe, where they present within the week or two acutely to trauma or to the general practitioner. So timeline wise, they could either present acutely or they could present insidiously, very slowly. That's the first thing to make note. The second thing to make note, with direct symptoms, often it involves diarrhea. It would be typical increased frequency of going to the bathroom. Often they may have blood or mucus in their stool. They can have significant bloating, abdominal pain accompanies all of this. And if it's a long-standing disease, unfortunately, it may present with weight loss, with lethargy, with anemia as complications. So some patients would present after some period of time when they can be quite fatigued and disabled to a degree.
There's a question that's come through. So we'll just take the question before we continue the discussion. Assalamu alaikum wa rahmatullahi wa barakatuh. I am 67, female, lactose intolerant. My issues are dealing with acute diarrhea and constipation. Tried home remedies for relief. Shukran. Maybe you can just comment on that.
Just to comment on that. So with lactose intolerance, that's a common disease in the community. One can be predisposed to this as a primary problem, where it presents in a young sort of child who cannot tolerate lactose. So our body needs lactase enzyme, and this enzyme digests lactose. And lactose is found in our dairy products, especially our milk products, our fresh milk, our fresh cream. So if one consumes lactose and does not have the enzyme to digest it, unfortunately, the residual amount of milk that's there undigested will bloat. It'll give us acute diarrhea, it'll give us cramps and gaseous type of symptoms, and therefore we would then make the diagnosis of lactose deficiency. It could be partial, it could be complete, and as one gets older, many patients can slowly develop this condition that they may not had previously, or it could be from another type of disease that's occurring in the gut. So a secondary phenomenon, we call it. So in her case, I would advise her very briefly, of course, to just pay attention to her diet if she's lactose deficient. It's not just your milk, it has to be your fresh milk, it has to be even your desserts can have lactose. Be careful what one is consuming, evaluate that carefully. And then at the age of 67, if there's an altered bowel habits that one has not had for a number of years and there's nothing dietary to find, one should see the general practitioner, because at that age it's very important to have screening tests done. At that age, one can unfortunately be at risk of more insidious, more concerning conditions. That's where we would advise a colonoscopy, probably.
Any questions, you may forward them to us via WhatsApp on 060-904-1056. 060-904-1056. We're talking to Dr. Yusuf Mullah, a gastroenterologist. Our topic for discussion is inflammatory bowel disease, ulcerative colitis, and Crohn's disease. So if you have any of these conditions, you require any medical advice, then you may call us, or you may send us a WhatsApp on 060-904-1056, and Dr. Yusuf Mullah will attempt to answer your questions, inshallah. Now, Dr. Mullah, just prior to having taken the question from the listener, you were discussing some of the symptoms of inflammatory bowel disease. You will continue with that?
Yes. So in summary, a change in one's bowel habits, and often it'll present with diarrhea. The diarrhea has mucus probably blood. You can a lot of urgency. So one needs to urgently go to the bathroom to relieve themselves. Often one may feel after relieving themselves that they haven't relieved themselves. That tenesmus can be a problem. As I mentioned, it could present acutely for a number of days or weeks, or it could present chronically over a number of months. So those are the presentations that often we would see. Accompanying or associated features would involve abdominal pain or bloating. And so certain presentations may favor Crohn's, some may favor ulcerative colitis. Purely on clinical grounds, it may be tricky to differentiate between the two. And to add more, besides the colonic symptoms or the gut symptoms, these conditions can actually have associations outside the gut. So one can present with certain rashes, joint pain, back pain, certain disease of the eyes. So this can actually, 5 to 7% of patients may present with what we call extra-intestinal disease, and that's something to make mention of.
Now, which age group is affected by this condition?
Yeah, so previously we often thought that it was the younger age group presenting with this disease. It still is probably peaking around the age of the 20 to 30-year-olds age group. However, we have seen patients in the more older age group as well. Now with more availability to colonoscopy and more education, where doctors are aware of the disease, we have older patients that have also been diagnosed with this condition for the very first time. But I would say it favors more patients in the 20 to 30-year-olds.
Let's talk diagnosis. How does one sort of diagnose inflammatory bowel disease?
So when one suspects this condition on clinical basis, as I mentioned, with the classical symptoms, and we're not talking about a food poisoning or tummy bug, we're talking about symptoms that are not abating. So with that clinical picture, there are blood tests and stool tests that one may perform if you're choosing to do non-invasive tests. This may involve inflammatory markers in the blood and the stool specifically. If these are in keeping of inflammation, then one would advocate for one to have a colonoscopy done. So instead of doing a CT scan initially, this particular scenario would often end up doing a colonoscopy. That is still remains the gold standard for diagnosing the disease. Not only do we diagnose the disease, but we also stratify it. We can quantify it. We can look at the complications, how bad is the disease, and that allows us to then start treatment.
Now, you mentioned the word colonoscopy. What is a colonoscopy, and is it a high-risk procedure?
Gee, that's a good question. So colonoscopy involves looking into the colon and evaluating the colon lining, the mucosa of the colon. So patients are asked to have a consultation with a surgeon or the gastroenterologist, and thereafter the consent is taken for this procedure. And often what we will tell patients, we show them pictures on where we're going to look at. Patients are prepared a day before for this to clean out or cleanse out the colon. And once that's done, they often will present to the day clinic or the hospital setting for the day. They put off to sleep with sedation. And once they're fully asleep, we would then introduce a very thin scope into the back passage to look at the full extent of the colon. That basically is a colonoscopy. Patients would wake up in a drowsy state, not remembering what had occurred. And with that, we would then discuss the findings. So that's how it sort of entails. I would regard it as more of a low-risk procedure. At certain times, of course, everything has risks, but it's regarded as a low-risk procedure overall.
Thank you for that, Dr. Moolla. Salams, I am a 35-year-old female recently diagnosed with ulcerative colitis. I am still struggling with abdominal cramps and diarrhea, currently on sulfasalazine. Do the symptoms go away over time, and does diet play a role in symptoms?
Yeah. I'll start out the question. So in terms of the disease, we have lines of treatment, and sulfasalazine it's a mesalamine drug. It's probably the first line of treatment one would use. So initially, if you had to think of it in a very simple way, we would often step up the treatment. So if sulfasalazine was started at a certain endpoint with discussion with your doctor who started the treatment, if remission or the disease control is not achieved, we can assess that with asking simple questions and working on certain scores by asking questions. We can do blood tests and stool tests, or we can ultimately repeat the scope actually. But if the remission is not there, the first thing is to get the colon under control. And Faizal, you can look at it like, there's a fire going on there. So we got to make sure that fire is controlled and abated. And then we would say the colon is now calm, and your symptoms may not be directly related to inflammation. So that's the first point that we would do. So we often would review patient, and if the colon is still inflamed, we'd escalate treatment. So if she's on sulfasalazine, depending on the dose, if that's optimal, and depending on the duration, one would have to consider stepping up treatment. And of course, the different modalities of treatment have to be discussed individually, but step up would be what one would think. In terms of food, which is the second part, so the food doesn't directly cause inflammation. Contrary to what many may think, it doesn't contribute to inflammation per se. But obviously, if the colon is inflamed, if we have a burn wound on our hand right now and put salt in there, of course it's going to hurt. So often we tell patients to avoid triggers that will irritate them, triggers that will cause too much of gases and distension of the colon. So certain foods one should avoid, and definitely have healthy foods to allow healing to occur at the optimal basis.
Question that comes through is, where is doctor based? Which hospital? Doctor is based at the Gateway Hospital and also the Life Mount Discom Hospital. And the second question comes from the same listener, says, what happens with excessive gas?
Excessive gas. So that's a difficult question. So excessive gas often is from maldigestion. It's often from maldigestion. It can be part of irritable bowel syndrome as well. So maldigestion means a certain food hasn't been fully digested. And that is one explanation. Another explanation may be fermenting type of foods. So with fermenting type of foods, if one has to consume a lot of that, unfortunately, that's where the gas comes from. And if we had to talk of some of the fermenting foods, if the listeners want to know out there, so your fermenting foods would involve your high fiber foods, that is very fermenting in nature. Your legumes, your beans are very fermenting in nature. Some of your green leafy vegetables, your cabbages, your cauliflower is fermenting. Even yeast is fermenting to a degree. So certain patients could handle high amounts of that. Many patients may not handle high amounts of that. So alter the foods to have less fermenting type of foods. And if you have a digestive disorder, like we spoke initially, one of the listeners spoke about lactose intolerance. If that is a factor, one has to not have lactose, so one does not have maldigestion. So that's the most common reason for gas. If one has to take antibiotics, you would wash off your enzymes and have maldigestion, and you would end up in gas. So there's many reasons for it. And unfortunately, we got to just see if there was a trigger, see if the gut is recalibrating itself, and ensure that one is not having any dietary factors that could contribute to this.
060-904-1056. You may forward to us your questions via WhatsApp, 060-904-1056. Now, Dr. Mullah, what if a person has been told that he has something called diverticulitis and that he has to come on a regular basis for colonoscopies? Now, at what interval should he be going?
Yes. So diverticulitis is not exactly part of inflammatory bowel disease. So diverticular disease, we say diverticular disease, that's a colon that has these certain, I like to say, potholes in the colon. So they're little weak spots in the colon. They can be extensive. They can be located to a certain area. So usually if it's diagnosed either via colonoscopy or via imaging, we would often counsel the patient about what could happen with diverticular disease. We actually don't routinely do screening colonoscopies for them. So if they have diverticular disease per se, we wouldn't screen them routinely unless there's a symptom that's advocating for us to go and look to see if there's a problem. They often would end up getting scopes for screening for cancer, for polyps, more than the diverticular nature of what's going on in the colon. Diverticular disease can complicate, unfortunately, in some patients where they have irritable bowel-like symptoms. Very rarely there can be inflammation around the diverticuli. Very rarely one can bleed from a diverticuli. And unfortunately, diverticulitis is where the diverticuli are actually now inflamed from an infection. And that can lead to a burst colon, or what we call perforation, an abscess that needs to be drained. That's a dreadful complication to have from diverticular disease.
Coming back to our discussion on inflammatory bowel disease, you did mention that there is no particular age group. Initially, it was the younger generation, but now it's the elders are also getting it.
Yes.
And let's talk treatment.
Yes. So with treatment, an acute setting of treatment.
I think what we do, let's take an ad break. Sure. We'll talk treatment on the other side of this. Otherwise, you're going to go into the ad break. So I think let's take an ad break. We'll continue on the other side of this, inshallah.
This hadith is sponsored by Ashraful Aid, International Humanitarian Organization.
حديث أدي قال رسول الله صلى الله عليه وسلم الصلاة عماد الدين. Salah is a pillar of deen. Salah is the most important form of ibadah. When we perform our salah, we are showing our obedience to our Creator. Salah is the key to Jannah.
This hadith is sponsored by Ashraful Aid, International Humanitarian Organization.
Are you looking for a meaningful way to fulfill your zakat obligation? Look no further than Ashraful Aid. With our trusted track record, your zakat reaches those who need it the most in the most honorable and dignified manner. Visit our website at www.ashrafulaid.org.
Sunnah a Day, proudly brought to you by Sunpick, 100% pure sunflower cooking oil. Sunpick, cook more with less.
Sunnah a day, it is sunnah to lick one's fingers and clean one's plate thoroughly after finishing a meal.
Sunnah a Day, proudly brought to you by Sunpick, 100% pure sunflower cooking oil. Sunpick, cook more with less.
Imagine this. You're putting together a 7-color meal, from the creamy pasta to the glazed carrots and flavorful onion gravy. This entire meal is made with our 100% pure extra virgin olive oil from our La Familia range, bringing outstanding quality and taste to your kitchen. Shop La Familia 100% pure extra virgin olive oil at any leading supermarkets near you. La Familia, heart of the home.
Your perfect companion. Radio Al Ansar.
Doctors and guests on a medical files program will help you with any medical problems you have by giving you advice on air. However, they do not have your full medical history and they have not seen you. Please verify the advice given to you on air with your doctor who knows you better. Neither the doctors nor Radio Al Ansar will be held responsible for any ill health caused by the advice given on Radio Al Ansar.
Medical Files brought to you by the Islamic Medical Association of South Africa and hosted by myself, Faizal MJ Suleman. Our topic for discussion is inflammatory bowel disease, ulcerative colitis, and Crohn's disease. And our special guest this evening is Dr. YUSUF MOOLLA, a gastroenterologist practicing at the Gateway Hospital and at the Life Mount Edgecombe Hospital. Now, Dr. MOOLLA, a few questions that have come through. The first question says, Salams Faizal, please ask doctor, yogurt is a good source as other dairy products will give diarrhea. Patients will on dairy have a low phosphate level. What doctor advises to supplement the low phosphate level? I am a sufferer of ulcerative colitis for more than 20 years. Please close the topic with how to combat this disease, as many people have ABS and inflammable bowel disease. Got the question?
Okay, there's a few parts there, no problem. So in terms of the yogurt, yes, many yogurt is processed. Many of the yogurts we find are processed. They have probiotics in them as well, and they're lactose friendly. So if you look at the sign of the yogurts, turn them around. If they're lactose friendly, they usually they process and actually safe to take. And often I tell patients, just try a small amount, see if you can tolerate it. Generally, many of them advocate that they sort of healthy for our microbiome or gut enzymes. If you can tolerate it and it works well, it shouldn't be a problem. Some patients, however, would actually say that yogurt may irritate the gut. So I think with that note, depending which type of yogurt one is having, pay attention to that. In terms of talking about the disease itself and in irritable bowel. So irritable bowel, let's remind ourselves, irritable bowel syndrome, that's a different condition. That condition can present with similar symptoms. However, the blood tests, the stool tests, even the scan and the scope and the biopsy that one would perform, which actually will come back normal. So the pathology in that disease, or what happening at the background of that disease, isn't inflammation. In simple terms, I would say it's more sensitivity. Patients can have constipation, can have diarrhea, can have constipation alternating with diarrhea. Often there's also bloating. There can be abdominal pain. Urgency could be affected there as well. So it can look like inflammatory bowel disease, and often these patients end up getting screened for inflammatory bowel disease, but the treatment is quite different. We have seen patients that may have sensitivity and inflammatory bowel disease. So the inflammatory bowel disease would calm down with treatment. The scopes would show disease is calm, but the symptoms are still lingering at the background, not correlating to the degree of inflammation one is seeing. and that's where we would say that there may be an overlapping irritable bowel.
Thank you for that, Dr. Mullah. Salam's recently diagnosed also had C. diff bacteria, was treated with vancomycin. Bleeding has stopped, but the cramps are still there. How do you treat the cramps? It goes on throughout the night.
Yeah, okay, sure. So C. diff is that's an infection of the gut. So not really part of inflammatory bowel, but that is a infection. It's another topic by itself. It's infection that can be there for many risk factors that the patient may have. If the C. diff is there and we think it's causing symptoms, one would treat it. Vancomycin is first line, and that's often taken, it's taken orally instead of via drip for at least 10 to 14 days. If the doses are right, it should clear the C. diff. The first thing that I would advise is one needs to make sure that the C. diff is actually cleared. So the toxin is not there, the C. diff is cleared. If the C. diff is cleared, then as we spoke about, these enzymes in our gut, the enzymes will need to repopulate, and as it repopulates, the digestive symptoms should start to abate. So one should go easy on the types of foods they're having, on the bloating foods and the complex foods. Have less of that. You could try some probiotics for sure, and give it time to settle in. Unfortunately, there is such a thing as a recurrent or a resistant C. diff, where one now has to take second line treatment. That's something else that one needs to bear in mind.
Jazakallah khair. The other question that comes is, my dad, 63, has Crohn's disease, currently on Asacol and biologics, had 3 infusions done so far. How long does one require this for? And what are the possible long-term side effects? Can IBD ever be reversed with diet and lifestyle changes? I think there's 2 topics, 2 questions in one.
Yes. So Asacol is, of course, very mild treatment for Crohn's. Many of us may not sort of use it, or maybe at the background, and we're trying to taper it down. But the infusion sounds like a biologic. So that is one of the strong treatments we use. There are many different types of biologics. So, of course, the name is not stated which biologic is being used there. The general biologic, we call it an anti-TNF, unfortunately does have some risk factors, but one has to weigh the risks versus the benefits in these patients. So risk of infection is there because this suppresses our immune system. In our setting, unfortunately, risk of TB is always something to discuss with patients, that one could be at risk of that, so one has to be cautious. And the other small fine print risk factors, from leukemia to lymphoma to cardiac failure, very, very rarely, but it has to be mentioned. So the doctor managing the patient should discuss this, should always monitor for this, should do routine blood tests. In terms of, I said you have 3 infusions, so if it is the infusion I'm thinking about, it does work quite fast. We often would give it for at least 4 to 6 months to see if there's meaningful difference, and then do the test to see if the Crohn has calmed down. Unfortunately, it's chronic treatment. So to answer the second part of the treatment, the question, diet alone hasn't been shown. Allah knows best, but it hasn't been shown to be effective in getting the colon calm. It is an immune disease, so we do have patients on minimal treatment after many years, and the immune system has maybe calmed down by itself, and the disease is more in remission. Despite being on very mild treatment, they're actually doing quite well, and we're just doing surveillance for them. So it can occur when one goes into self-remission, but I think my ultimate advice would be, whatever route we're doing, it should be supervised. One shouldn't self-treat and self-medicate. The treating gastroenterologist should be supervising the care. Even if we're weaning off treatment, the monitoring should be supervised.
Salam's doctor, irritable bowel syndrome is said to be an illness involving the gut microbiome, the mind, gut axis, psychological causes, and often referred to psychiatrists as well. Question is there any inflammation involved in IBS? And secondly, somewhere else it says IBS could be a form of bowel allergy, and an antihistamine medication like ibastine is used. Can you comment on this?
Okay, Jay. So yeah, there's a few points to make note. So with irritable bowel, as we mentioned before, often our inflammatory markers would be normal in irritable bowel, unlike inflammatory bowel. So our markers, from our stool markers to our blood markers, should be normal, unless there's another superimposed disease on the side in this particular investigation that we're doing in this case. So it should be clear. That's number one. Number two, in terms of how one would manage it, the microbiome has many different involvements in the gut, and we're still learning about it, to be honest with you. It's something that is evolving. In irritable bowel, yes, there is a nervousness to the gut that's driven by our emotional axis. They talk about the limbic axis. So the emotional areas of the brain, when they did studies initially, they actually saw those areas flare up when the gut was irritable. So if one is anxious, and I use a classical example, Faizal, a classic example, that if one is going to write the exam in the morning and they got irritable bowel diarrhea type, they would go 3, 4, 5 times to the bathroom. After the exam, they're back to normal. So it's heightened in these patients where it's more than normal, unfortunately. So we are aware of this anxiety component. Not all patients need to go to a psychologist, psychiatrist, unless that disease is overwhelming. So often we wouldn't, recommend that. But if we can identify just with a consult that somebody is very anxious, borderline on an anxiety disorder, then we would recommend a psychologist or psychiatrist. But not everybody needs to see a psychologist, psychiatrist.
Thank you for that, Dr. Mullah. Salams. What could possibly be the problem if my mother, who is 80 years old, has bloating and some nausea, unable to eat and loss of appetite for the last 6 weeks, been to doctor, prescribed Nexiprax and Myrtle. Nexiprax caused vomiting. What do you suggest? Jazakallah. Bloods were clear, no inflammation.
Gee, so that, it's difficult to focus on the individual case, but with nausea, it can come from many different reasons. I mean, nausea can be present often if one has a gut infection. Nausea could be from significant reflux, one is regurgitating a lot, and that's why I can see why the doctor prescribed Nexipraz. One could even get nausea from gallbladder disease, for instance, or there's something obscuring the output of the stomach. So if there's a lesion around the liver, around the pancreas, in the stomach itself, that could lead to decreased emptying of products from the stomach. And very rarely, if we had to do a scope and if we had to do an ultrasound or a scan, and as I said, the bloods were normal, so there's no renal impairment, no urea that's high, liver failure. I mean, there are central causes for nausea as well. So if one had to exclude certain causes in the gut, we actually will even do a CT scan in the brain in certain individuals, because a brain lesion, a medullary region as well, a lesion can actually contribute to nausea from a central cause. So yeah, patient probably needs further investigations if the initial treatment has not worked.
060-904-1056. 060-904-1056. Our topic for discussion: inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Our special guest, Dr. Yusuf Mullah, a gastroenterologist. Now, Salam's question for Dr. Mullah, since he's a gastro: recurring gas buildup and acid reflux. Any suggestions? Jazakallah, Dawud Asma.
Yeah, so it's a very common complaint that we get. So that's more on reflux, not so much on inflammatory bowel, but of course we can allude to that. Patients who have a lot of regurgitation and gas buildup with burping and with some sort of acid, the first thing that we speak about, which involves treatment and some of the triggers for this, often certain triggers would involve what we're consuming again. So if one has to have carbonated drinks, that would be a cause. If one has to have citrus, that could be a cause as well. Spicy foods can be a cause. A large meals, often we're working hard in the day and we're having a large supper. A large meal may contribute to regurgitation with gas in terms of belching and burping. A trigger with reflux as well that we know is actually having a late night snack, believe it or not. So that can also contribute to reflux in the evening. We wanted to eat food and lie down quickly. Those all are contribute to reflux. So there's a certain lifestyle factors. If one is stressed, smoking is also a risk factor actually. These are all things that we can try to manage. Obesity, put pressure in the stomach, these can all contribute to reflux. And if one has removed all of that, we would often investigate patients to search for an hiatus hernia to make sure there's nothing in the stomach contributing to a disrupted sphincter at the entrance of the stomach. If that's clear, we manage it like reflux, like we commonly manage. And unfortunately, some patients need to go on antacid medication, which is one of the most commonly used drugs worldwide.
Salams, what tests are done to check progress of ulcerative colitis?
So in summary, what we spoke about initially, the diagnosis tests are actually the follow-up test to make sure that the disease is calm. So in certain individuals, we may, of course, do their bloods routinely to make sure the meds are not causing side effects and the inflammatory markers are down. There's no complications like anemia, for instance. They often would get an annual colonoscopy. That is the best test to compare, and we compare apples with apples. So if the disease was distributed throughout the colon, very severe, the exact same scope done on treatment, will show, inshallah, the disease has calmed down. So that's, that makes complete sense. And nowadays we do have some stool tests available that can actually give us an objective number, and that number being followed up on treatment will tell us to continue treatment, or to decrease the dose, or to increase the dose, or to change treatment. So that's exactly what we do. And you can think of it like treating diabetes. If the sugar is high, you're going to add treatment. It's a similar thing, but it's not just the sugar here. We're going to do a few other tests.
We've got like 30 seconds for the ad break, but I'll take the last question before the ad break. Please advise on a good probiotic.
Yeah, there's many probiotics out there, and there isn't any simple answer for that. It can be quite expensive, and the different strains that one can use. So in general, I think we gotta answer the question, why are we taking the probiotic? So often we would use it if one is on antibiotics, number one. The second reason we would use it is if one had a very bad bout of diarrhea and now wants to reset the gut. To use it chronically isn't advocated, so there isn't any guidelines that I can recommend that it should be used chronically, routinely. And normally the different strains are there. If it has lactobacillus, that's often the one that we would prescribe and use. But again, I think we got to pay attention to why is one thinking of using it, instead of which one we should use, because most of them are actually very similar in the market, and some can be very expensive.
Thank you for that, Dr. Yusuf Mullah. Time for us to visit the marketplace. We'll continue on the other side of this. Do stay with us. The question
This Eid al-Adha, the Al-Imdad Foundation offers you a unique opportunity to share your Qurbani with Palestinian refugees and displaced families in Gaza. Our canned Qurbani program allows you to provide a ready-to-eat high-protein meal to starving Palestinian families. For just 3,450 Rand per share, we will slaughter, can and distribute your Qurbani. Donate in your name, for a loved one, or in honor of our beloved Prophet, peace be upon him. Visit alimdad.com or call 0861 786 243 for more information.
Welcome to Simplex Radio. Visit our showroom for the full range of car audio. Our TV department carries top brands with quality LED panels, full HD to Ultra HD, and now the experience of Super Ultra HD. Visit our theater rooms and transform your home with brands like Onkyo, Integra, Denon, Boston Acoustics, Yamaha, and more for quality audio visual experience. Now available, full range of home appliances. A one-stop shopping experience. Call 031 306 4029 or Kenilworth Park, 202 Brickfield Road, Overport. Simplex Radio, the name you can trust.
Experience Ghiyarwi Sharif in Baghdad and a full Iraq Ziyarat tour with Show Mirage Travel, 28th September to October 9th, 2025. Visit Baghdad, Qazimain, Karbala, Najaf, Kufa, and more with a Cairo stopover. Return flights, visa, insurance, hotels, and transfers included. Personally escorted by Ridwan Ismail from 41,786 per person. Call 031 208 4222 or email ridwan@miragetravel.co.za. Show Mirage Travel. We take you there.
This weekend, join the Radio Al-Ansar team at the Magma Agri Fair. 2 days of non-stop fun and entertainment. We're talking live cattle auctions, amazing shopping, mouth-watering food, and tons of fun for the kids. It's a weekend you don't want to miss out. So come on down and join us live from Camperdown at the Magma Agri Fair, May 24th and 25th. See you there.
Teaching you something new every day. Radio Al-Ansar.
Doctors and guests on the Medical Files program will help you with any medical problems you have by giving you advice on air. However, they do not have your full medical history and they have not seen you. Please verify the advice given to you on air with your doctor who knows you better. Neither the doctors nor Radio Al-Ansar will be held responsible for any ill health caused by the advice given on Radio Al-Ansar.
Medical Files brought to you by the Islamic Medical Association of South Africa. Our topic for discussion: inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Our guest, Dr. Yusuf Mullah, a gastroenterologist. Dr. Mullah, I am non-dairy. My blood test always shows low phosphate, weakness of bones, and tiredness.
Gee, because the bones and tiredness. Okay, we're not sure the patient's age. Is that
no age.
So if one cannot have with the bones and the dairy, so to link that in the question, if one it's ideal in our elderly patients to at least get put a gram of calcium in, and some vitamin D, of course, for bone health. It's often advocated to get more in dietary measures, in food products, than in taking any supplements. So if one cannot have dairy and one is, of course, becoming older in age, we would advocate taking a supplement for calcium. So one actually at least have at least 500 milligrams, I would say, daily of calcium in a supplement. You get many different types, the tablets, the dissolvable ones. So if you cannot have dairy at all and you worry about bone health, I would suggest to get a supplement that has calcium and vitamin D. There's many of them out there.
Okay, thank you, Dr. Mullah. Now, can inflammatory bowel disease be treated? And if you're going to tell me yes, I can see you are nodding your head, so I think I look at it as positive. What is the treatment?
So to outline the treatment of inflammatory bowel disease, we unfortunately have to use steroid often in the acute setting to get the colon calm. We try to use it for a very limited period, but the steroids have many side effects. So we do not want to use steroids long term. So therefore, we would use it to bridge onto treatment that does not have steroids. So the one listener mentioned sulfasalazine, that's a mesalamine type of treatment that is used in mild ulcerative colitis. That's a tablet, and there's a suppository that can be used with mesalamine. We would then use more immunosuppressive drugs if that drug fails. And the common drug, the older drug that used is called azathioprine. So that is an immunosuppressive drug. It works through our immune system. And as I mentioned initially, how the disease starts off with the immune system, this calms down the immune cascade, so the body doesn't attack itself. The bowel doesn't get inflamed. And of late, over the last a decade or so, they've developed biologics. And biologics are immune drugs, but are very specific. So they work on very specific pathways. Unfortunately, they carry a cost, and there are newer biologics out at the moment. These are either given via infusion, via an injection, or tablets, which are now available. So those are biologics. So those are the medical treatments, and we would tailor it depending on somebody's age, the risk factors, the disease distribution, how severe the disease is. And very rarely, unfortunately, if all disease fails and one is extremely ill, especially acutely ill, one has to resort to surgery. One has to remove the colon. And that's not common, but that is an option for some patients, unfortunately.
A question that comes on Facebook says, Salams, I'm gluten and dairy wheat intolerant, but sometimes get gut leak. It comes from Sister Yasmin Khan.
Okay, Jay. So with gluten, so with gluten, you get gluten that can be gluten sensitivity. So that's what I'm thinking when she says gluten intolerant. So gluten sensitivity, where you're getting a lot of gluten associated symptoms, which either may be allergic or just may be intolerant. So one just feels very tired, very fatigued, very gut heavy taking gluten. There is a disease that goes with gluten called celiac disease. Now that's slightly different from sensitivity. And my advice would be to ensure that she does not have celiac disease. It's more Caucasian type of disease, but we have some of our patients that have it in our local community. So that's one disease to exclude called celiac disease. And that can create, I think, which means leaky gut. We're talking about malabsorption. So that can have malabsorption if the gluten is creating, if the gluten is part of celiac disease. So I would advocate for that to be excluded. That's excluded. It's an intolerance that is commonly found, not commonly found, but more noted in this day and age. Many of our celebrities, said they have non-celiac gluten sensitivity. International tennis players, etc. Djokovic is one person that comes to mind where it says he's gluten intolerant, and it presents like IBS. So the treatment for it is to avoid gluten, as simple as that.
Salams, my calprotectin is 6,800. What level will show improvement, and that treatment is working? What foods must I avoid, and what drinks will help the colon?
So calprotectin of 6,000 is extremely high. So calprotectin is one of the stool markers. We said it's a stool inflammatory marker. It should be less than 50. We can accept less than 100, 150. If it's more than that, especially more than 300 to 400, it means there's some inflammation going on in the colon. It can go up with blood. It can go up with infection. So if there's no infection and there's no bleeding from another source, that calprotectin has to be explained as to why it's high. So I'm assuming the inflammatory bowel disease is active, and treatment needs to be escalated. In terms of foods, as I mentioned initially, foods will play a trigger to cause more symptoms, but maybe not so much inflammation in this disease. So patients should just avoid what food triggers more symptoms. But unfortunately, because it's not causing inflammation, it's not going to have the calprotectin so much. The treatment is going to be the one, inshallah, that will have the calprotectin to decrease, which means we're getting into remission.
And are there any foods that I must avoid and any drinks that can help?
Nothing in particular. So often we tell patients to do a dietary history, and if bloating is a factor, I mentioned the fermenting type of foods that one should avoid. Over and above the bloating foods, it's often individualized with different patients. Some patients may tolerate spicy sort of foods. Some may tolerate certain sauces, but not certain sauces. Some may talk about tomatoes. We've heard a range of different things, but when you look at the disease pathology, foods wouldn't really call this inflammation, but as I mentioned, if you have a burn wound and you put salt in there, of course it's going to hurt. So the inflammation needs to be calmed down, and that's where the treatment comes in.
And what are the complications of this disease?
Gee, so unfortunately, the disease has complications. So if one has to look at the complications of inflammatory bowel disease, it's quite vast. So acute flare-up can be a nasty complication where the colon just gets super inflamed, a lot of diarrhea, dehydration, bleeding, and it can actually burst. So that's an acute complication. The more chronic complications is unfortunately cancer. So the colon is very red hot and inflamed. And if we look at the picture of it, I will show it to you. It looks nasty. It tries to keep healing itself. And over 8 years to 10 years of uncontrolled disease creates the milieu or the breeding ground for precancerous growths, and that's where patients can end up having an early cancer in the face of inflammatory bowel disease that's not controlled. You can also get narrowing called a stricture, where the colon can close up and get narrowing. So Crohn's disease patients that get disease of the small intestines, this can create bowel obstruction. So that's also a very, very bad complication to have. Other complications may involve anemia. If the disease is always active, there's always microscopic bleeding. The body doesn't want to absorb iron from the inflammation. So patient can become iron deficient. That's difficult to treat, and that's part of the disease. There are other complications as well. As I mentioned, it can affect organs outside the bowel, including the skin and the liver and the joints.
We've got like 3 minutes to round up, doctor.
Yeah.
But are there any cases or examples of patients that you managed to like to discuss with us very quickly?
So we can speak about one case that comes to mind. One of our brothers that was self-treating and had the disease diagnosed many years ago. Was seeing one of our colleagues, and I saw him more when he came to hospital with severe abdominal pain. And this individual was self-treating and hasn't had those scopes done, like I mentioned, routinely annually. And Allah knows best, but screening was not being performed because he just defaulted and was self-treating with prednisone. And when he presented, he had to get a scan done because he was has bowel obstruction. And lo and behold, he unfortunately had a sigmoid cancer in the background of ulcerative colitis. So this disease required an operation. Well, alhamdulillah, he's done well over many years. This cancer has been removed. He has a bag now. He still has a lot of his colon left, and he still needs treatment. He's very positive-minded. But this case teaches us that we should stick to the guidelines, to the knowledge that Allah has given us, and we should take the treatment and do things under supervision. And lastly, another case that I can talk about is a young lady who actually presented very ill, and she lost a lot of weight, and she stopped going to school. She was actually not doing well at all. She started on the first and second line of treatment and really wasn't doing well. And the first time I saw, I was almost brought to tears looking at her. Very malabsorbed, a lot of weight loss from the disease, and the disease was confirmed. There's no doubt about it. So alhamdulillah, we started straight on to one of the biologic drugs. And within weeks and within months, being on steroids, that was stopped. Her weight started to increase. She started to become functional, normally active in functionality, and the disease has calmed down so much. And she's actually returned back to activities. And this is a very, very young patient I'm talking about. Some in the teens. So to do those two cases is important learning points. That if there's symptoms, we should seek help. We should be compliant to treatment, and inshallah, there is solutions that are available to us.
90 seconds. Salams, what's the success rate of colon removal when you have severe colitis? No biologicals working?
So that takes more than 90 seconds. So it depends on what operations one is talking about. So when you remove, if it's ulcerative colitis, it's only the large colon. Technically, if you remove the entire large colon, you've cured the disease. You won't need treatment probably. So the success rate can be very good to curing the disease. The issues is what operation one is getting, and what we're doing to reconstruct the gut. So often get our colon surgeon involved here. there is surgery that one would create a pouch. So one would make a rectum if the rectum was very inflamed and that has its own issues. So although you may have cured disease, you may have replaced it with a small side effect, if you know what I mean.
She had ulcerative colitis.
Yes, JD. So one might want to create a pouch because the rectum is involved here, and that pouch will have its own implications of frequency to the bathroom. The pouch can also get inflamed late in life and can break down. So it may not cure the problem entirely, but it takes away a lot of burden of disease. If one just sits with a bag or stoma, we call it, one can have good quality of life and one can function normal. And you and I may not even say that somebody's sitting there with a bag. It does not smell. It has no sounds. There's nothing there. Often people are afraid of it. So it cures the disease, but it does replace it with another small problem. And that's, I think, the conclusion of surgery. It has benefits, but one has to be fully counseled for that.
Thank you so much, Dr. Yusuf Mullah, for joining me. To all those listeners whose questions we haven't answered, we apologize to you. Time's totally run out. And thank you to all the technicians at the various radio stations that have been also, doing the technical duties this evening. Thank you for the job well done. And thank you to the listeners for the questions that you posed. Dr. Yusuf Mullah, I thank you once again. All the best to you. Assalamu alaikum wa rahmatullahi wa barakatuh to you.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Jazakallah for having me in the studio, and I hope that the listeners have enjoyed the show.
No, absolutely. I think it was a wonderful, thank you for all your answers, etc. And as the time is up, I'll be back with you on another Medical Files program, inshallah ta'ala, in 2 weeks' time. But for myself, Faizal MJ Suleman, it's Assalamu alaikum wa rahmatullahi wa barakatuh.
الذي قد غادر أحب الوفاء بشتى الصور أحب الوفي الأمين الأغر فأهل الوفاء كلون السحاب وحسن الربيع وماء المطر أحب الوفاء بشتى الصور أحب الوفي الأمين الأغر فأهل الوفاء كلون السحاب وحسن الربيع وماء المطر مقامهم فوق رأس الجبال وفوق الروابي وعند القمر ويا من تحب غياب الوفاء رأيتك تهوى غياب البصر وكم قائل قد
Radio Al-Ansar 24/7 365.
An informative Islamic global perspective. This is Al-Ansar News.
On the 20th of May, the news from Durban 90.4 FM, Peter Maritzburg 105.6 FM. Health workers protest after Prince Mshiani intern doctor dies. America Monina. Health workers and activists have been picketing in Mlazi today to demand justice following the death of a medical intern last week. Aluluto Mazwi collapsed while he was at work at Prince Mshiani Hospital. Report says the 25-year-old was allegedly forced to report for duty at the pediatric ward last Monday despite being healed. The peaceful protest outside the hospital gate